Good morning, everybody. It gives me great pleasure to introduce you to my friend and former close colleague, Dr. Alejandro Hoberman. I met Dr. Hoberman in 1989 when he came to the University of Pittsburgh and the Children's Hospital of Pittsburgh for medical school and residency in Buenos Aires. And he was there to accept a fellowship in ambulatory pediatrics and community medicine under the leadership of a legendary pediatrician, Jack Paradise. Dr. Hoberman was an exceptional fellow. He was wide-eyed, enthusiastic, curious, hardworking, and extremely productive. He naturally flowed into a faculty position at Pitt and Children's Hospital of Pittsburgh in 1992. I actually became his division chief in 1994, and we worked closely to provide outstanding clinical care to the marginalized children of the Pittsburgh inner city, and to match that clinical excellence with excellence in clinical research. When I stepped down as division chief in 2001, it was Dr. Hoberman who took the reins of the division. He has done an exceptional job in all areas, taking the division to heights I hadn't even imagined. He currently heads the Division of General Academic Pediatrics. He is the executive vice chair and vice chair for clinical research within the Department of Pediatrics. He established, funded, and holds the Jack L. Paradise Distinguished Service Professor in honor of his research mentor. Dr. Hoberman's research focuses on common conditions that affect children. In the area of ear infections, he contributed studies to enhance prevention, diagnosis, and treatment. He published a series of studies in the New England Journal of Medicine, sponsored by the National Institute of Allergy and Infectious Diseases, evaluating the efficacy and the adequate duration of antimicrobial therapy in young children with acute otitis. The study he recently reported in the New England Journal was sponsored by the National Institutes of Deafness and Communication Disorders and evaluated the efficacy of tympanostomy tubes in children with recurrent otitis media. In the area of urinary tract infections, Dr. Hoberman evaluated the prevalence, diagnosis, treatment, and follow-up imaging of children. He published in the New England Journal of Medicine a National Institute of Diabetes and Digestive and Kidney Diseases study sponsored by that organization, evaluating the efficacy of antimicrobial prophylaxis in children with vesicular-ureteral reflux. And he received the Clinical Research Forum Top 10 Clinical Research Achievement Award in 2015 for that research. The Pittsburgh research team has recently completed 2 NIH-sponsored UTI trials evaluating a short course of therapy for UTI in children, and another study led by his protege and now colleague, Dr. Nader Sheikh, a study evaluating corticosteroids in preventing renal scarring in children with febrile UTI. His influence is obviously far-reaching. He served on NIH special emphasis panels, FDA, NIH strategic planning groups, and AAP guidance committees. I want you to know that as division chief, he didn't ignore teaching. His division was actually the recipient of the 2009 Academic Pediatric Association Outstanding Teaching Award. And in 2017, while still division chief, Dr. Hoberman took on the administrative responsibilities as president of the UPMC Children's Community Pediatrics. It's a large primary care pediatrics organization in Pennsylvania with 58 offices and over 900,000 yearly visits. So in the Pittsburgh system, the academic and community pediatrics are now linked through a single leader. With all of this impressive accomplishment, Alejandro has remained the warm, enthusiastic, generous, deeply loyal, and trustworthy person I met over 30 years ago. That's why I'm so excited for you to meet and learn from him. Dr. Hoberman.
Thank you, Heidi. Good morning. Thank you, Dr. Leonard, for inviting me. Thank you, Heidi, for inviting me. Thank you for the warm introduction. It's wonderful to be visiting with all of you here at Stanford. My goal for this morning is to talk about improving accuracy in the diagnosis and management of acute otitis media in children. I have to disclose that I have 2 patents through the University of Pittsburgh, one related to a reduced clavulanate concentration of amoxicillin clavulanate, and a second one that looks at aids in the diagnosis of otitis media, classifying tympanic membrane images, and I'm an advisor to Kaizen Biosciences. Acute otitis media is a very common pediatric infection. It accounts for 18% of ambulatory visits. In the 1 to 4-year-old group, it's about 11 million visits every year. There are 280,000 tube operations in children aged less than 3 years of age at a direct cost of $2 billion and about the same amount in indirect costs. The peak incidence is during the first 2 years of life. 60 to 70% of children have an episode of acute otitis media before their first birthday. Onset during the first 6 months of life is associated with recurrent acute otitis media, and recurrent acute otitis media occurs in about 20% of children. The figure on the right shows on the vertical axis patients, on the horizontal axis time, and acute otitis media is like life. We know where it starts, we know where it ends. The difference is the quality of what happens in between. The red dotted line represents spontaneous cure, and we use antimicrobial treatment so that for any given number of patients, symptoms will resolve sooner, and that's the delta 1, or that at any given time, a smaller proportion of children will exhibit symptoms. I'm planning on using the American Academy of Pediatrics key action statements to describe diagnosis and management of acute otitis media and complement it with findings of 3 large randomized clinical trials, all of which were NIH funded and all of them were published in the New England Journal of Medicine over the last 10 to 15 years. So to start with diagnosis, and we can see the images at the bottom. On the left, we have a normal tympanic membrane, then mild bulging of the tympanic membrane, moderate bulging of the tympanic membrane, and severe bulging of the tympanic membrane. Then we see an eardrum with intense erythema, another one with intense erythema, which are patches of hemorrhage on the tympanic membrane, and finally a pink eardrum that could be associated with an upper respiratory infection but does not have miliary effusion. So the American Academy clearly states that clinicians should diagnose acute otitis media in children who present with moderate to severe bulging of the tympanic membrane or new onset of otorrhea not due to acute otitis externa. So that would be the moderate or severe bulging of the tympanic membrane. 1B, clinicians should diagnose acute otitis media in children who present with mild bulging of the tympanic membrane and recent, less than 48 hours, onset of ear pain, holding, tapping, rubbing of the ear in a nonverbal child, or intense erythema of the tympanic membrane. So if they have mild bulging, they need other findings of acute inflammation like intense erythema or otalgia. And 1C is that clinicians should not diagnose acute otitis media in children like the pink eardrum who do not have middle ear effusion. On the right side of the figure, you see the algorithmic thinking that whether the child has suspected acute otitis media. The first question is whether bulging of the tympanic membrane is present or absent. If it's present, it's acute otitis media. It's absent, then the question becomes, is there opacification of the tympanic membrane or an air fluid interface? If yes, that would be otitis media with effusion. If no, it would be no effusion. And I will get back to this algorithmic thinking as we then talk about artificial intelligence in acute otitis media. The first of the clinical trials I want to talk about was a placebo-controlled study we conducted that was funded by NIAID and NICHD, in which we assessed for eligibility about almost 1,400 children. About 500 were eligible to participate, 291 underwent randomization, and we ended up including in the analysis, in the intent to treat analysis, 144 in one group and 147 in the second group. And the demographic and clinical characteristics of all these studies are going to be remarkably similar. The first one shows that over 50% of the children were between 6 months and 11 months of age. And as you can see, always a little bit more boys than girls have acute otitis media, and all the rest, race, maternal level of education, type of health insurances. There were no differences between the two treatment groups. Let's focus on selected demographic and clinical characteristics. On all these table ones of all these large clinical trials, you're going to see that about half the kids are exposed to other children. And we define exposure as being exposed to at least 3 children, at least 10 hours per week. We're going to see that the baseline score on symptom score, like the acute otitis media severity of symptom scale, which has been is in the process of being registered with the Food and Drug Administration as the patient-reported outcome tool for acute otitis media. Dr. Sheikh is taking the lead of doing that. The scores were similar between the two treatment groups. About half the children have bilateral disease, and about 3/4 of the children have moderate or marked bulging of the tympanic membrane. On the outcomes of this study, on the first figure on the left, you can see a significant finding, because that was the achievement of a score of 0 or 1 only one time, which is kind of inconsistent in children with acute otitis media because they get better and then they get worse. So our statistician recommended, Dr. Roquette recommended using a couple of scores, getting 2 consistent scores that show a score of 0 or 1 on the acute otitis media severity of symptom scale, and that finding was significant. And on the figure C, you can see the mean score over time, which is what the FDA actually likes the most for using this PRO, to use a number that describes the symptomatic improvement of the child over the 10-day period. The primary outcome of this study was the presence of bulging of the tympanic membrane at the end of treatment failure, with or without symptoms, in most cases with symptoms. And you can see that the children that receive amoxicillin clavulanate had a failure rate of about 16% versus those who received placebo, in which half of them, 51%, were still having a bulging tympanic membrane at the end of treatment and was considered treatment failure. And this was regardless of whether they met criteria for what we call severe acute otitis media, using the American Academy of Pediatrics definition, which is a temperature more than 39 degrees, or moderate or severe otalgia, or non-severe acute otitis media. I mean, clearly children with severe acute otitis media had higher failure rates, but there was about a 3 times more failure rate if they were not treated with antibiotics among those who had severe otitis and among those who had non-severe otitis. Then we looked at specific characteristics at entry: exposure to other children, the presence of a score of more than 8 on the acute otitis media severity of symptom scale, the presence of bilateral disease, and the presence of marked bulging of the tympanic membrane. And we looked at the different treatment groups and tried to see if the effect of these predictors was additive, and it was. If you look at children that had one of those predictors, about 30% had treatment failure. If they had 2, it was almost 60%. If you have 3, you've got 75%. And if you had all 4 findings, exposure, a high score, bilateral disease, and marked bulging of the tympanic membrane, 100% of the few children that were in that category had treatment failure. Once we looked at adverse events in a placebo-controlled study like this one, there was one child that developed mastoiditis in the placebo group that resolved fairly fast within 24 hours of hospitalization and treated with ceftriaxone. There was a little bit more protocol-defined diarrhea among children who receive antibiotics. There was more diaper dermatitis among children who received amoxicillin clavulanate. There was more oral thrush among those who received antibiotics, but there were more perforations of the tympanic membrane among those who did not receive antibiotics. We then combined the findings of our study with a very similar study that was published by Paula Taitanen from Finland in the same issue of the New England Journal of Medicine. because we were concerned about lining up patients from the least severe to the most severe categorization of acute otitis media. So we first have unilateral non-severe, unilateral severe, bilateral non-severe, and bilateral severe acute otitis media. And we combined the two studies only with the finished data in children less than 24 months of age, because their study went up to 35 months of age. So we used only the data under age 2, as our study was only under age 2. And then we looked at the relative risk and the number needed to treat in all the categories. And there was no difference whatsoever in the relative risk, in absolute risk reduction, and of course, number needed to treat was the same in the unilateral non-severe through the bilateral severe group, which contradicts what the American Academy of Pediatrics ended up recommending in the 6 months to 2 years old for the unilateral acute otitis media without otorrhea, in which they gave an option of observation there. And the number needed to treat is exactly the same as the bilateral severe acute otitis media. So let's move on to the second key action statement that deals with antimicrobial therapy. So it says that clinicians should prescribe amoxicillin for acute otitis media when a decision to treat with antibiotic has been made and the child has not received amoxicillin in the last 30 days, or the child does not have concurrent purulent conjunctivitis, or the child is not allergic to antibiotics. Clinicians should prescribe an antibiotic with additional coverage for acute otitis media when a decision to treat has been made and the child has received amoxicillin within 30 days, or has concurrent purulent conjunctivitis, or has had acute otitis media that are responsive to amoxicillin. And clinicians should reassess the patient if the caregiver reports that the child's symptoms have worsened or failed to respond to initial antibiotic treatment within 48 to 72 hours and determine whether a change of therapy is needed. So if you treat acute otitis media, the answers are very simple. It's going to be amoxicillin or amoxicillin clavulanate according to the guidelines at 80 to 90 milligrams per kilo. Alternative treatment would be only if there is true penicillin allergy, but we do know that penicillin allergies are a lot less common than what we used to think. And the 10% that was quoted in the past is not true. It's most likely to be in the 2% range as opposed to the 10% range. When amoxicillin fails, the recommendation is to use amoxicillin clavulanate at 90 milligrams per kilo of the amoxicillin component, or if the child was treated with amoxicillin clavulanate, to use ceftriaxone, with the caveat that our group and Ellen Wald many years ago started using, instead of 50 milligrams per kilo, we use 75 milligrams per kilo, which achieves really high levels and allows you to use 2 shots instead of 3 shots. And we give the injections, intramuscular injections of ceftriaxones, separated by 48 hours, not by 24 hours. So we only use 2 injections instead of 3 daily injections. There is no mention of any cephalosporins. There is no mention to azithromycin or any other antibiotics. And the concern about cephalosporins like Cefdinir is that it provides poor coverage for beta-lactamase producing organisms, or for penicillin intermediate or resistant organisms. So it's basically amoxicillin or amoxicillin clavulanate, and then moving on to ceftriaxone. We then try to determine on the second clinical trial whether we can shorten the duration of treatment for children with acute otitis media. And sponsored by NIAID, on a contract with NIAID, we were supposed to randomize 600 patients, 6 to 23 months, over a 5-year period at 3 sites. The efficacy of antibiotics was going to be determined by using a consistent treatment strategy during the entire respiratory season. So every time these children had acute otitis media, they were treated with either a reduced duration treatment, which consisted of 5 days of amoxicillin clavulanate followed by 5 days of placebo, or standard duration treatment, which was 10 days of amoxicillin clavulanate in a double-blind fashion. And we looked at the impact on antimicrobial resistance because we saw them every 6 weeks on follow-up, and we obtained nasopharyngeal specimens. So again, there were about 1,569 children who were assessed for eligibility. Almost 900 were eligible to participate in the randomized trial. 520 underwent randomization, and 250 57 and 258 respectively were assigned to the 5-day or the 10-day treatment group for every time they had an ear infection during the respiratory season. And the numbers, and I said supposed before when I said 600 children, the 520 was lower than 600 because the Data Safety Monitoring Board of the NIH stopped the study at 520 because we have achieved our outcome, and they did not feel that it was ethical to continue to randomize patients when the superiority of the 10-day treatment group had clearly been demonstrated on 520 subjects. So again, table 1 shows the same population. Half the kids are 6 to 11 years of age, a little bit more boys than girls. About 60% of the children were exposed to other children on a regular basis, and so forth. And the bilateral disease the scores were the same between the two treatment groups, and bilateral disease was present in half the patients, and 80% of the children had moderate or marked bulging of the tympanic membrane. With regards to outcome, if you remember before on the placebo-controlled study, we had 16% treatment failure for 10 days treatment. We had the same 16% treatment failure in this repeated study. And we had 51% for the placebo patients before, and now we had 34% for the 5-day treatment group. So 5 days was not as bad as placebo and was somewhere in between the 10 days and placebo. So that was the main reason for us to recommend that 10-day treatment course provides the best outcome for children with acute otitis media. The symptom burden using the acute otitis media severity of symptom scale between days 6 and 14 was not significant, but there was a difference at day 12 to 14 because of the higher rate of treatment failure of the scores among those children. And the proportion of children who achieved a 50% reduction in symptoms was 91% for the 10-day treatment group and 80% for the 5-day treatment group. There were differences with regards to the number of days of antibiotics that they received, because every time they had a new infection, they were treated with either 10 days or 5 days. And there were no differences in the rate of protocol-defined diarrhea or diaper dermatitis. And there were no differences with regards to the rate of recurrences or the rate of miliary effusion between the two treatment groups. Now, we looked at the same prognostic factors that we talked about earlier in the placebo-controlled study. And in this particular case, the two that were significantly different was exposure to other children, because they did not include the number 1 on the odds ratio, and the presence of bilateral disease. And again, the effects were additive. If you had 1 or 2 of those prognostic factors, they were more likely to result in treatment failure. A complicated slide, but I'll walk you through it in a very simple fashion. So at the index episode, children had Streptococcus pneumoniae in the nasopharynx in high proportions, and children had Haemophilus influenzae in high proportions. Relatively low proportions were intermediate or resistant pneumococci, and about a third of the Haemophilus influenzae produced beta-lactamase. What happens when we use antibiotics for 5 or 10 days? If we drastically reduce the colonization with Streptococcus pneumoniae, and we do not touch Haemophilus influenzae in the nasopharynx, that has been well documented before. There is little effect of antibiotic on Haemophilus influenzae. But that goes down right at the end of treatment. When they have the next episode, they're exactly where they were whenever they started, and there is no difference between 5 and 10-day treatment groups. When they come for routine non-illness visit, Q6-week visits, there was no difference between the two treatment groups. And when they came in the months of April or May, at the end of the respiratory season, there was no difference in having used 5 or 10-day treatment multiple times for these children with regards to their colonization with Haemophilus influenzae or with Streptococcus pneumonia. So there was no impact on antimicrobial resistance whatsoever, except for a slight reduction of Streptococcus pneumoniae at the end of treatment in both the susceptible and the intermediate and resistant strains. So we concluded that among children 6 to 23 months of age with acute otitis media, reduced duration antimicrobial therapy resulted in less favorable outcomes than standard duration treatment, and neither the rate of adverse events nor the rate of emergence of antimicrobial resistance was lower with the shorter regimen. Let's digress a little bit to talk about adverse effects of antibiotics. Once we use amoxicillin, in multiple studies has been documented that children have about 17% or 18% of chances of having a diarrhea. We usually protocol-defined diarrhea as the presence of 3 watery stools in one day or 2 watery stools on 2 consecutive days. Once patients receive placebo, about 10% have been reported to have diarrhea. In the 2 studies I just told you about, in these 2 large randomized clinical trials, in the placebo-controlled study, published in 2011, 24% of the children who received antibiotics had diarrhea. And in the 10-day treatment course in 2016, 27% had diarrhea. In the study published by the Finnish group was even higher, 48% of children had diarrhea. We do know that in babies, particularly under age 2, we double dose them with clavulanate. They receive twice the clavulanate as an adult male or female would receive when they get treated with amoxicillin clavulanate. And we also know, because we've done work with Boston Medical Center with Steve Pelton at Boston, in which we used French strains of Haemophilus influenza that are high producers of beta-lactamase. And we tested a formulation we called LP001 that had half the clavulanate as the regular formulation that we can prescribe nowadays. So instead of being 14:1, had 28:1 of the clavulanate component. And we found that the MICs of those recalcitrant strains of Haemophilus influenza, beta-lactamase producing strains, was the same, and that was pretty much equivalent. So we then used the data from the placebo-controlled study and the 5 versus 10-day study. On the left side of the table, 401 children, the ones that received 10 days of treatment, to compare with an open label study that we reported in Antimicrobial Agents and Chemotherapy, where we cut down the clavulanate to 50%, 55% in the final part 2 of the study, which is the 72 patients on the right. So instead of getting 6.4 milligrams of clavulanate, they received 2.85% milligrams of clavulanate and slightly less amoxicillin. Instead of 90 per kilo, 80 per kilo. And we compare them with those historical controls. The population was a very similar population. Half the kids were less than 1 year of age. About 50 to 60% of the kids were exposed to other children on a daycare setting. The scores were about the same. Bilateral acute otitis media was about the same, and moderate or marked bulging of the tympanic membrane was present in 80 to 90% of the children enrolled in this study. And what we are able to find is that the protocol-defined diarrhea went down from the regular formulation of augmentin from 26% down to amoxicillin levels. 17% is when we found when we reduced the clavulanate by 55%. We also found that the diaper dermatitis was reduced from 34% to 22%, but most importantly, that the parents did not discontinue medication. It went from 10% of parents who stopped giving the antibiotic because of adverse events to 1%, 1 patient out of 72 discontinued medication. Treatment failure rates were similar, were actually a little bit better. My gut feeling is that it had to do with they basically took the antibiotic, and there were no differences in the scores or in the proportions of children who achieved a 50% reduction of the baseline scores on the patient-reported outcome acute otitis media severity of symptom scales. So a 55% reduction in the clavulanate component of the amoxicillin clavulanate resulted in a 33%, we drew blood from these children. So we did a pharmacokinetic study, and the Cmax went down by 33%. And the area under the curve went down by 5%, which tells me one of 2 things: that either the children under 2 years of age absorb a lot more clavulanate or that they have a reduced excretion because of not having achieved full GFR, or a combination of both. They absorb more and excrete less, which results in they have a bioavailability of clavulanet that is much higher than in older children and adults, and that results in the high adverse event profile of this medication. And we also found that both on the left for Streptococcus pneumonia and on the right for Haemophilus influenzae, the red dotted line shows the levels that are needed to achieve eradication of those organisms. That the levels that achieved with less than half the dose were sufficient for a period of time that is sufficient to treat the infection. And we're in the process of meeting with the Food and Drug Administration on launching a clinical trial that will be seeking approval for FDA label of this reduced concentration clavulanet formulation. I want to migrate now to diagnosis of otitis media, that algorithm that I shared with you at the beginning, and a little bit of thinking about artificial intelligence. And these are my partners in crime. Jelena Kovacevic used to be the head of electrical and computer engineering at Carnegie Mellon University. She's now the dean of engineering at NYU, and Nader Sheikh is my partner in crimes at General Academic Pediatrics. And we try to start discriminating between the three conditions: acute otitis media on the left, otitis media with effusion in the middle, with a fixed amber eardrum, and a normal middle ear status of no effusion on the right. And we started thinking about features, and we came up with 8 features. The first one, segmenting the eardrum and avoiding any presence of the ear canal. The second one, avoiding any kind of artifacts, whether it's a hair or cerumen that gets in the way. And we basically, what the software will do, will Photoshop those with pixels around those pixels, then takes the center area of the tympanic membrane and opens it up, measuring the number of pixels, then looking at lighting and looking at topography, looking at heat maps of bulging of the tympanic membrane. We secured 2 patents in this area, and then we compared an automated classifier like we use, which was 90% accurate, with generic classifiers. And then we gave the same images that we use for the classifier. We used about 200 images. We gave it to my partners in General Academic Pediatrics, and I picked up 3 or 4 people that were pretty good and asked them to look at the images and classify them. And we saw that the pediatricians were about 80% accurate, which is what has been reported over the years. So in other words, a vocabulary of using these features and a grammar which is articulating this distinction between normal and otitis media with effusion and acute otitis media, using that algorithmic thinking that I talked about in the first slide, using bulging and using opacification and these features, was better than generic classifiers and was better than the pediatricians. So then we started using this in the context of clinical trials and capturing images with endoscope originally, and most recently with the product that Welch Allyn has developed, which is the MacroView Plus that I'm using there on the slide, that allows you to connect the iPhone with it. And we capture and annotate the description of the tympanic membranes. Some of these children actually had tympanocentesis in the context of treatment failure, or in the context of other studies that we're doing to determine autopathogens causing acute otitis media. So we then took it a notch further and tried to apply machine learning principles to this, and work with a company called Decipher Analytics, and they used 2 approaches. The first one was a multi-layer, an MLP approach, and a multi-layer perceptron, or MLP, is a feed-forward artificial neural network that generates a set of outputs from a set of inputs. MLPs are generally suitable for classification prediction problems where inputs are assigned a class or a label. Not only we did the MLP approach, but then we asked them to use a decision tree approach, exactly the same as we otoscopists tend to think about children with acute otitis media. In other words, is there a bulging present, yes or no? Is there opacification present, yes or no, in the absence of bulging? And very interesting highlighted in red in that table, the MLP diagnosis achieved a sensitivity, the recall is the sensitivity of almost 95%. And on top of that, the decision tree was also identical, it's 94.74%. And the specificity was in the 70% range. So now we have an artificial intelligence tool that gives us the answer whether it's acute otitis media or not acute otitis media, and gives us a confidence level on the bottom of this slide there of a percentage, 75%, 76%, whatever the number is. And what Nader and myself and Tim Shope in our division are trying to do next is trying to determine what will constitute high level of confidence versus low level of confidence, because we don't want to provide a number, we want to provide high or low for the pediatrician or the emergency room doc or the nurse practitioner to be able to make a decision whether it's acute otitis media or not. So we are trying to figure out when do we disagree with the artificial intelligence answer, and that will become low level of confidence. We've done it on about 30 to 40 children. We need to do about 10 to 20 more over the next few weeks to finalize the application. So what we did is we developed an 8-feature algorithmic automatic classifier. We validated it in an initial project with about 200 eardrum images and achieved 90% accuracy. We compare it with generic classifiers that achieve 70% accuracy. We compared with experienced pediatricians that achieved 80% accuracy. We secured 2 patents. Then this hardware folks caught up with us, and now they have an otoscope. And of course, there is an endoscope made by Storz that can be connected to the iPhone that are off the shelf. Our application actually uses voice recognition, and we tried every voice recognition software you can think of, from Alexa to Siri, and we ended up using Google as the right one. So we talk to the iPhone, we say, capture and stop, and it stops the recognition. And then we can edit the clip with bars to make it short, submit, and we get the answer, whether it's AOM or no AOM, and the level of confidence. And we gathered 1,000 eardrum videos annotated by the panel of experts. And then we developed the advanced programming interface that gives the binary outcome and the levels of confidence. We're integrating that in the final screen of the application. And we plan on registering this as an FDI type 1 device or an adjuvant tool in diagnosing acute otitis media. And we haven't completed that process yet. So let's take a deep breath and now move to recurrent acute otitis media. So the American Academy of Pediatrics, with regards to recurrent acute otitis media, highlighted that we should not use prophylactic antibiotics to reduce the frequency of episodes of acute otitis media. And it quoted a Cochrane review from 2006 that used 16 antimicrobial prophylaxis studies. Antibiotics really worked for recurrent acute otitis media, decreased the number of episodes by 1.5 episodes, and they were reduced in half during the time that the children took the prophylaxis. But we should not use it because it's the best way of generating resistance. So the American Academy went on to recommend that clinicians may offer tympanostomy tubes for recurrent acute otitis media. And that's defined as the presence of 3 episodes in 6 months or 4 episodes in 1 year, with 1 episode over the preceding 6 months. And that was based on 5 RCTs that enrolled about 105 children, old studies with unclear or high-risk bias, all of them except one conducted prior to introduction of pneumococcal conjugate vaccine. But we know from those studies, one study that had 95 children, that the proportion of children who developed no acute otitis media recurrence at 6 months went down from 46% to 5% whenever they had tympanostomy tubes. And the number needed to treat was 3. We also know from the other study that enrolled 200 children that the proportion of children with no AOM recurrences at 12 months went down from 48% to 34%, and now the number needed to treat it was 8. We also know that the number of AOM recurrences at 6 months went down from 2.17 to 0.67. So there was a 1.5 episode reduction, similar to what the antibiotics prophylaxis used to provide. We also know from the other study that it went down from 1.7 episodes to 1.15 episodes by 12 months. So it was reduced over time. We do know that children that got tympanostomy tubes did not have better quality of life based on the OM6 questionnaire that Rich Rosenfeld developed at 4 or 12 months than active monitoring. And we also know that kids that got tympanostomy tubes did not have persistent tympanic membrane perforations, although we do know from a study that Dr. Feldman and Dr. Paradise did in the 90s that whenever children were randomized to get tympanostomy tubes or not get tympanostomy tubes for persistent middle ear effusion, that the ones that had tympanostomy tubes did have significantly more focal atrophy, tympanosclerosis, retraction pockets, and chronic perforations of the tympanic membrane. So this time working with NIDCD, we designed a phase 3 multi-center randomized clinical trial between 6 and 35 months. This time we went a little bit older. We went all the way to 3 years of age, children with recurrent acute otitis media. We randomized 240 children to tympanostomy tubes on medical management at Children's in Pittsburgh and Children's National Medical Center, and we followed them for 2 years. The primary objectives were to determine the extent to which tympanostomy tubes reduce the rate of acute otitis media recurrences over a 2-year period. And the hypothesis was that tympanostomy tubes will reduce the rate overall, and secondarily, high risk versus low risk children for recurrent ARM will experience greater benefit. And secondary objectives were to determine whether tympanostomy tubes versus medical management resulted in reduced antimicrobial resistance of nasopharyngeal pathogens or greater cost effectiveness in the high risk versus the low risk groups. Primary outcome was the mean number of acute otitis media episode per child year, but we followed them for 2 years. Secondary outcomes, the proportion of children with treatment failure, time to a first episode of acute otitis media, frequency distribution of episodes of acute otitis media, the proportion of episodes that were considered severe, cumulative number of days with tube otorrhea, with AOM symptoms, number of days that they received systemic antimicrobials, adverse events, otorrhea, diarrhea, dermatitis, the proportion of children with resistant organisms at routine follow-up visits at the time of acute otitis media and at the end of the respiratory season, and the use of medical and non-medical resources, missed work, special childcare arrangements, and the use of quality of life questionnaires like the OM6 or the caregiver impact questionnaire, and parental satisfaction with treatment. We define treatment failure in a complex way, meeting again the criteria for recurrent acute otitis media. So if we randomize them because they had 3 in 6 months, if they had 2 more over the next 3 months, or 3 in 6 months, or 4 in 1 year, they will be considered a treatment failure and offer the tympanostomy tubes if they were not in that group. We also, anytime the parents decided that the children needed to get tubes, it was considered a treatment failure. Long periods of systemic antimicrobial treatment, more than 45 days within a year. Long periods of otorrhea was considered treatment failure. Long periods of middle ear effusion, a perforation of the tympanic membrane that stayed for more than 90 days, protocol-defined diarrhea for more than 30 days, a hospitalization related to acute otitis media, or an untoward reaction to anesthesia was also considered treatment failure. We randomized children within strata, age, and exposure to other children, 1-to-1 to get tympanostomy tubes or medical management. They saw the ENT for tubes within 2 weeks, those that were randomized to tympanostomy tubes. They were treated with floxing or fluoxacin twice daily for 3 days whenever they had acute otitis media, and then culture-directed treatment if they didn't improve. And we saw them every 8 weeks, and within 48 hours, the parents suspected acute otitis media, or within 5 days of respiratory symptoms. And we documented using the same form that we have used in all the clinical trials and captured images of the tympanic membranes. 240 children were to be randomized with recurrent acute otitis media. We would do an interim analysis halfway through the study. We were looking for a 33% reduction in the number of episodes. We expected that we were going to see a surgical reduction of about 1.5 episodes per year, and assuming that we will have 25% crossover or attrition over the 2-year period. The primary outcome was the rate of acute otitis media episodes per child year over the 2-year period. And it was an intention to treat analysis using multivariate imputation via chained equations for missing data, primary outcomes. Secondary outcomes, in the per protocol analysis, we excluded the children that were assigned to tympanostomy tubes who did not get surgery. We censored the data for those that were assigned to medical management when they got the tubes. And we use sensitivity analysis for missing data for all the other outcomes. Again, 1,300 children were assessed for eligibility. About 1,000 were potentially eligible. We continue to screen them to see if they develop recurrent acute otitis media. 250 instead of 240. This time we over-enrolled a little bit just in case, and were randomized to receive tympanostomy tubes or to receive placebo. There were 13 children in the tympanostomy tube group whose parents declined, even though they agreed to randomization. Once they were randomized to tubes, they declined to have the tubes placed. And there were 54 patients of the 121 that were assigned to the medical management group who ended up receiving tympanostomy tubes. Of those 54, there were, again, 19 parents who, after randomization, decided they didn't want to wait and they wanted the tubes in spite of them consented to participate in the study. Within a few weeks to a month, they received tympanostomy tubes. So similar to the 13 patients that decided not to get tubes. But there were 35 that ended up getting tympanostomy tubes because the protocol dictated that they will have to get it because they met criteria for recurrent acute otitis media a second time. So again, same population of children. Half the kids, most of the kids were under 2 years of age, only like 7 and 9% respectively, 10 and 7% respectively were more between 2 and 3 years of age. Again, more boys than girls, similar between the two treatment groups. In this case, these children had recurrent acute otitis media, so most likely to be in a daycare setting. 80% were exposed to other children, and almost all of them they were equally divided between having high risk for recurrence or low risk for recurrent acute otitis media. Main outcome of the study was that the rate per child year over the 2-year period did not differ between the two treatment groups, 1.48 versus 1.56. It was clear to us that during the first year of the study, compared to the second year of the study, children had during the first year twice as much ear disease as during the second years. So things got better over time because children grew and the eustachian tube works better and they have less acute otitis media. There were no differences in the frequency distribution of the episodes. Interestingly enough, there was no difference. Dr. Wald in the editorial on the New England Journal of Medicine pointed out that children who received tympanostomy tubes tend to have less severe ear disease. That wasn't the case. So half the kids had non-severe and severe acute otitis media, and they were equally distributed in both treatment groups. Of course, there was more treatment failures among the ones who had medical management, and that is strictly related to the 19 parents who opted to have the tubes placed immediately after randomization. If you take those 19 patients out, there's no difference at all between the two treatment groups. And of course, there was more urea amongst the ones that got tympanostomy tubes, and there were more symptoms of acute otitis media among the ones that did not have tympanostomy tubes. And there were no differences, among all the other outcomes, quality of life, use of medical resources and non-medical resources between the two treatment groups. And Nato Sheikh is publishing a paper on the cost effectiveness, and it's not going to be cost effective. And that's to be reported soon. There were no significant differences, although there was a little bit more diarrhea among the ones that got medical management compared to tympanostomy tubes. There was more urea among the ones that got tympanostomy tubes. And basically, the main benefit of tympanostomy tubes was that it delayed by about 2 months the occurrence of the first episode of acute otitis media. That was significantly different between the two treatment groups. It was a secondary outcomes, time to first event, but there was no difference in the rate of episodes and all the other outcomes that we discussed. Interestingly enough, there was no difference in the likelihood of children who had multiple courses of antibiotics versus the one that got tympanostomy tubes, he having a non-susceptible pathogen at the time of acute otitis media visits. There was no difference in the likelihood of having a non-susceptible pathogen in the nasopharynx at non-illness visits. And there was no difference at the end of the respiratory season. So it had no benefit with regards to antimicrobial resistance, which is a frequently quoted reason to place tympanostomy tubes, so we can use topical drugs and avoid antimicrobial resistance. So it wasn't the case. So what did I tell you during the last 45 minutes? I told you that acute otitis media is frequently misdiagnosed, that tympanic membrane bulging should be required, that in children 6 to 23 months with acute otitis media, antimicrobial therapy is beneficial. It reduces the time to resolution of symptoms and the symptom burden. The rate of persistent otoscopic signs of acute infection, bulging at the end of treatment, and that's regardless of laterality and likely severity of the infection. I also told you that children 6 to 23 months with acute otitis media, reducing the duration to 5 days resulted in less favorable outcomes than the 10-day duration, with no benefits with regards to adverse events or the emergence of antimicrobial resistance. I also told you that tympanostomy tubes was not superior to medical management in reducing the 2-year rate of acute otitis media episodes, and that further research is warranted on improved diagnostics and the enhanced safety profile of the antibiotics we frequently use for acute otitis media. I just want to pause and thank you very much for your attention. And Heidi, back to you.
Oh my goodness, Alejandro. I think that your body of work is the kind of chapter that we should give to residents and fellows to demonstrate how to be a really outstanding clinical researcher. So we have a couple of questions here, and I thought I'd start with some that are not quite as tightly tied to the research, but seem quite interesting, and then some that are more tied to the research. So the first one is, what have you seen in COVID in terms of the prevalence of acute otitis media and the age distribution of the condition, especially in the period where children spent more time at home?
Sure. Thank you. I just want to highlight that all this work is not my work. This is a team sport, as you can see on the slide. That's our team of nurse practitioners, research nurses, research assistants, faculty, general academic pediatrics faculty, and Jack Paradise and Bob Hickey, whenever Jack turned 90 years of age at his last big celebration. COVID, to answer your question, acute otitis media disappeared. We had to stop all the studies that we were doing, and we stopped seeing any other viruses, and children, of course, were not in daycare. I think it's coming back slowly. It's not at the levels that it used to be, but we are starting to see a lot more rhinovirus, a lot more respiratory syncytial virus. We had multiple cases of flu over the last few weeks. So I don't think there was an age change. I do see acute otitis media in older children, and I saw a bunch of cases over the last few weeks, but we are seeing acute otitis media in the young children as they go back to daycare. So I think we're slowly going back to normal, to what it used to be currently.
Thank you.
But it's not there yet.
Okay. There's a question about how you envision using the automated system for looking at the tympanic membrane and sending the information, and the AI algorithms for determining acute versus recurrent or chronic otitis media. How could we use those in low resource settings?
So I would think about the process for the use of these tools. It's very preliminary. It would be to eventually have decision support systems where you would have one otoscope that, and these are relatively not very expensive otoscopes. That the one that I tested recently from Welch-Allyn is a little bit more than the otoscopes we use in all clinical settings, that allows us to capture into the electronic health record an image. the dream would be that a patient will walk in and the image of the tympanic membrane could be obtained like a vital sign, where into the electronic health record, you will get an answer of AOM, no AOM. And then if you think otherwise, you'll have to look again because the tool is going to be right. The problem is that in many instances, particularly in babies, we're going to be running into cerumen. And the only way of looking at the eardrum is going to be for the pediatrician to clear the cerumen from the external auditory canal in order to be able to look at the eardrum and then use the decision support tool. So I view it not as diagnostic, as something else that we have in our armamentarium to actually guide us on what to call a bulging acute otitis media. And it's not going to be acute otitis media versus otitis media with effusion. We may be able to work that in the future, but as of now, it's going to be treatable versus non-treatable, AOM versus no AOM.
I see. Okay. I wonder if we could get to the point where we give parents a set of instructions to clean and prepare the ear so that there doesn't have to be quite as much digging for cerumen.
Heidi, thank you. Thinking about the parents, there is a push and there is an advertisement by one of the pharmaceutical companies. They actually advertise it as the makers of Tylenol, in which they have an otoscope that they are going to market to parents for relatively inexpensive cost. So in the era of telemedicine, there are telemedicine devices that could be used to look at the tympanic membrane too. So the market of this could end up being the parents sharing with the pediatrician if the quality of the otoscopes get better, what's available to them, or if we can teach them, or there's an easy way of clearing the cerumen for them to use. And it could be an enhancement for telemedicine visits.
Okay. So there's a question about the role of eustachian tube stents, self-absorbing, in children rather than tympanostomy tubes. Could you address that?
I have no idea on using stents. I am a general pediatrician. I'm sorry. I have no ENT knowledge about the use of stents. I don't have any experience with placing tubes in the outpatient setting to prevent anesthesia either. I can do tympanocentesis on children, and we frequently do it, but I have no experience, and neither I have seen any strong data in our ENT group to support the use of stents.
Okay. How about could you talk about topical treatment in children who have ear tubes, and that in comparison to oral treatment?
Yes. So I was impressed, and Jack Paradise actually warned me about this with the study that you did with him when children were randomized to get tympanostomy tubes. Once you start seeing children who get tympanostomy tubes, the otorrhea becomes a nuisance, and it happens for long periods of time. That's why we had as criteria for treatment failure the presence of more than 45 days of otorrhea during the 1 year per year of follow-up. The treatment was with topical floxin or floxacin drops. If the children did not improve, we will do culture and we'll supplement with oral antibiotics after they had received topical drops for like 5 to 7 days and were not improving. And yes, then we'll do culture-directed therapy based on what the findings of that culture of the ear canal would be. But when we culture, we generally go in and suction and don't do a culture of the ear canal. We try to get a specimen from the middle ear through the tube.
Well, we've come to the end of our hour together. This was rich and enlightening, and I really want to thank you for everything that you've done, this talk, and your immense contributions to the field of general pediatrics. So thank you very much, Alejandro, and thanks to the audience for your kind participation and attendance.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.